Okay, so we're going to switch now to a set of rapid fire, 5-minute lightning talks. If you want to stand up, get a cup of tea or coffee. It is a little chilly in here. Feel free to do so, but I'm going to bring on Professor Dilys Walker. Dilys is a professor of obstetrics and gynecology and the director of Global Maternal Newborn Health Research, the Research Cooperative at the University of California, San Francisco. She's also co-founder of Pronto International, an NGO that develops curricula based on highly realistic simulation and team training to improve intrapartum and newborn care. So Dilys is going to facilitate this set of lightning talks.
I'm not going to ring the bell, but someone is going to ring the 5-minute bell. And I'm just going to quickly reiterate these 5-minute lightning talks are to provide an opportunity for people to present a project, innovation, idea in a brief, insightful, inspiring, thought-provoking, useful, humorous, controversial, or enlightening way. So that's what we're headed for. I think we'll all wake up. We are going to start with Steve. Maybe everybody can come on up here so the transitions are easier. Steve Kretschmer, Dr. Niranjan Securty, Arnab Day, and Vishawajeet Kumar. If you want to come on up here, and then you can have a seat here, and then we'll do quick transitions every 5 minutes. Okay. We're going to start with Steve Kretchmer. He is managing director at Surgo Foundation, where he brings innovative approaches and tools to evidence generation and solutioning for more efficient and effective development programming. You have 5 minutes.
Okay, so there's been a lot of discussion about human behavior and motivation, what drives behavior in the clinical setting. And so I hope what we share today can help provide some insight into how to understand and assess that behavior, so the interventions that are created are targeted to specifically the drivers of that behavior and motivation. So what we know is that nurse practices don't align with their knowledge and skills. Knowledge and skills we know are incredibly important, but they're not enough to answer what drives their clinical practices. What we found in work that used applied behavioral science research methods is in the context of Uttar Pradesh and MNCH nurses in the facilities, they have, again, context is everything, as has been mentioned a number of times today. They have a very high workload, very low support, particularly from the medical officers. They're not viewed as an authority by the medical officers, by the families, by the patients. They get a lot of patient resistance and family interference. Punitive supervision, which was just discussed on the last panel, this sense of fear, and a low control of risk factors, many of which, by the time the woman comes in, it's already said and done. The complication is there, and she has to manage it. This leads to perceptions of stress, particularly due to a perception of risk to self and a lack of control. And so that then reframes her goals, whether consciously or non-consciously, to try to minimize the stress, avoid blame, and seek control. And therefore, she reverts to certain coping mechanisms using heuristics or short, quick decision mechanisms based on her own experience, avoiding responsibility where she can, asserting control where she can, and attempting to earn respect where she can. An example of this is the upfront screening process. A woman walks in the door, she needs to screen the woman. According to clinical guidelines, there's 23 steps that she needs to take in order to be able to properly clinically assess a woman. She uses 2 or 3 of those, so she's using heuristics. And in fact, when we look at what she uses, we see why she's using them. She does the vaginal exam because that tells her what's the status of the labor. She takes the woman's blood pressure because for her that's that tells her what the health of the woman is. And she takes the fetal heart rate because that tells her what the health of the baby is. She's now just assessed the entire situation from her perspective, except for all of these other stressors, right? And so what she also takes into account is a lot of non-clinical criteria. The man walked in the facility along with the woman, and he's upset because he's just been arguing with the ambulance driver about what he has to pay the ambulance driver. And she's now looking at this situation and, you know, what if something goes wrong? I have to deal with him. I think maybe this should be a referral, right? So it's not based just on the clinical criteria. So as a result, they have their own perspectives of their job. Our perspective is, she's your patient as soon as she walks in the door. You need to follow the clinical guidelines through all of these parts of the delivery management. And you need to monitor risks and support the woman post-delivery. Her perspective is she my problem? When she walks in the door, if I lay hands on her, she's my patient. If I don't, she's not my patient yet. So is this woman going to be my problem, or should I refer her right out the door right away because then I don't have to deal with it? Or is there somebody else I can give it to? Delivery management, that's the hot state because that's where there's very high risk perception of any issues. And then when that's done, when the baby's delivered, the woman's still alive, she seems to be okay, the baby's pink and crying, the risk is over. So now I go into a cognitive cold state and I will pass off responsibility or take my time. There isn't a need, there isn't a sense of active management. And then post-delivery, this just isn't my job. It's not. So when we go back and look at the behaviors, we see the practices follow exactly with this pattern. This goes to then the types of solutions, and I think, as again was mentioned on the last panel, some of these solutions are going to be very complicated. The first one, policy changes that address gaps in accountability and support, and that even goes to addressing the issues with punitive supervision, changing that sense of fear. This is something that has to change in the entire culture of the whole system. It all flows downhill, and it just happens that the staff nurse is at the bottom of the pile. Shift in community norms and expectations to align with what's expected of the staff nurses. This goes to actually the families, the ASHAs, all understanding what's expected and what that interaction should be. That, for example, if I go to the facility and I get there, it may be the case that I am referred by the staff nurse, and I should follow those instructions rather than resist them. And finally, interventions that actually are addressing nurses' internal behavioral drivers. So, looking at those factors, what can we do that actually change that context for the nurses? With that said, when we zoom back and look at staff nurses, what we can say is there's a framework by which we can understand all of these, untangle that motivation box that's in Dominic's model in order to really understand what are the factors that are driving motivation, and then be able to address them accordingly.
Thank you very much, and we'll have some time to discuss afterwards, but I think we'll move right on to Dr. Niranjan Securty. He is Director of the Populations Council's office in India. In this capacity, he provides technical and strategic oversight to the Council's innovative research, evaluation, and monitoring efforts in the country. He's almost 20 years of... You're ready for me to stop now? There's another sentence here. But I'll let you go ahead and start. Thank you.
No, I'm
Your
just
5
concerned
minutes.
about the
You
time.
don't want to take something.
Yeah. Okay, it's quite chilly here, and I'm going to raise a controversial issue so that, we all get warmed up. The issue that I'm raising is more about the point that, in fact, Chandra made a few minutes back about who is thinking about the service providers' view on this quality of survey, the quality improvement. And is it more to do with when we say the client-centric program, the quality improvement, are we talking about more on the client's perspective, or are we talking about the health systems taking into consideration, or are we talking about somebody who is facilitating this service improvement from the facilities? So let me start by saying that at least in the family planning quality improvement work, way back in 1990, as Dominic pointed out this morning, the Bruce and Jane framework has literally brought out the clear guidelines about the client-centric focus program in case of the family planning. It talked about the importance of the client provider information. It talked about how the client satisfaction to services becomes the key outcome indicator, not just, it's not only the important for the method adoption, but also the continuation of the family planning method, which is very critical. Many studies have shown that the post that framework that was kind of identified, there were many studies which have shown that the quality of care improvement is indeed necessary to make sure that the family planning continuation exists and that you reduce the discontinuation and the method removal. So what's critical here? Since then, all the studies that were done have pointed out to one thing, and that which came out in the very recent review done by the Catherine Tumlinson on the quality improvement metrics, where she has pointed out, saying that there is no common definition across these studies, because we all consider, and in terms of both the quality improvement from a programmatic perspective and also from a measurement perspective, we all consider context as a background to defining what the quality improvement in a given geographic setting or in a program. May I ask a question, whether the context, is it an excuse for the program people, or is it really critical? Can we not come up with an agreed definitions about what this quality improvement is, and what kind of person-centered quality of care are we talking about? That's one of the questions, because if you look at, I have chosen this one particular slide that came out of the quality of care studies that were done in both Bihar and UP by many of the organizations. Some of them are here. It talks about 2 points. One, the quality of care. For example, if we ask a client, have you received your method of choice? About 62% have stated that, yes, I received my method of choice. Is it good enough to define that there is a good quality of care in the facilities? But on the other hand, when we look at the information cascade, in terms of the method selection process that went in case of the family planning, what we see is that only 28% have actually received, by definition, the informed method choice. So where is the gap? The gap exists between how we define and what we perceive from a programmer's perspective, or the program manager's perspective, or from an evaluation or the researcher's perspective within the measurement framework on how do we define that quality. So what is the problem here? The problem is that program managers could say, yes, the woman is coming to a service facility to opt for a particular method. Shouldn't I just give the method that she wanted, with the ensuring that presumably good quality of service? because these two concepts within the family planning, and so is the maternity care, is the quality of service, the service offered versus the service received. And the service offered more from the perspective of the program managers, which talks about the facility quality of care, more of the clinical quality rather than the person-centered quality. So the point here is that even if you look at the difference between those who received informed method choice, the graph on the right bottom, what you see is that among those who received informed method choice, not only that there is a kind of selection or the information gap for the method selection process, but also there is a information gap in terms of whether or not they received sufficient information about the particular method that they have chosen. So here the challenge or the question that I would like to pose is that where does the buck stops? Is it that it's the problem of the measurement, are the researchers, or is it the problem of the program thinking in terms of whether woman who comes to the facility, should it be that my facility has got good infrastructure and the clinical quality and the technical capacity? Should it stop there, or where does the buck stops? That's what I want to hand. Thank you.
Thank you very much. Appreciate that. We're going to move right along to Arnab Day. He's Assistant Vice President at Sambodhi. Arnab manages the research portfolio and provides strategic support in conceptualizing various measurement, learning, and evaluation assignments. He has a strong foundation in MLE with more than 6 years of experience leading a number of large-scale evaluations across various thematic areas. He currently anchors the MLE imperatives of the TSU in UP and is deeply interested in understanding issues of inequities, heterogeneity, and person-centered quality care.
Thanks, Dilys. So I'm going to start with something that Mrinal alluded to earlier this morning about some of the contextual level factors that affect quality of care. To begin with, I think quality of care, in a sense, is a rapidly evolving field, and me being a very young researcher in this area, I personally feel that over the last few years have been exceptionally vibrant in terms of the number of different programs and pathways that have been implemented and tested. Also in terms of the methods and measures that have been adopted to measure the impact of these programs. Some of the examples that we have seen in terms of the programs being implemented are say the use of checklists or different styles of mentoring, quality improvement, and more recently the peer-based mentoring approach. While the rigorous evaluations are able to test the efficacy and effectiveness of these programs, they often fall short of telling us and giving us a very in-depth understanding of some of the factors and crucial determinants that affect quality of care in a more deeper way. One of these aspects that we talk about is the facility's readiness to change towards improving quality of care. There's a large theory that has already been developed in the field of implementation research. Professor Brian Wiener from the University of Washington actually in his seminal work around facility readiness emphasizes that organizational readiness is something which is like which is a psychological state in which the members of an organization are committed to change, and at the same time they feel confident in their collective ability to do so. So that is something that we wanted to test and in our own settings in Uttar Pradesh. And what we did was to use this theory and used some of the data from our quality of care surveys that Sanjeev was mentioning earlier in his panel. From the data that we had from 2 rounds of quality of care, we developed a composite index for quality of care. Using that index, we identified outlier facilities both in intervention and comparison geographies. And we really clubbed them into 3 basic buckets. One were facilities which were performing exceptionally well with a nurse mentor present. One were facilities which were performing exceptionally poorly in spite of a nurse mentor being there. And the third bucket was a bunch of facilities which were performing exceptionally well, even when there was no nurse mentor present in those facilities. And we looked at psychological and structural level factors, both at the individual and facility level, to study facilities' readiness to change. And what we found, I think what Mrinal was also mentioning earlier, was that irrespective of a nurse mentor being present or not, some of the factors like MOIC's motivation, the motivation and willingness to learn in terms of the staff nurses, the simple fact whether a staff nurse resides in within the premises of a facility or not, the average age of staff nurses, the peer-to-peer communication and coordination and cooperation between staff nurses, these all played a significant role in improving the facility's readiness to change, their willingness to change, their change balance. And we also found that even in facilities that did not have a nurse mentor but had that kind of an enabling environment, so to say, did perform exceptionally well, did had that kind of a change valence, which led to them providing quality of service delivery. Now, whenever we sort of synthesize these findings and talk to colleagues at the foundation and other partners, we are immediately sort of hit back with the question of so what? So what do we do with these findings? Because as you would have noted that a lot of these findings are very intrinsic to the facility. They are very systemic in nature. I mean, things that we may or may not be able to change that easily. So I do not have a very clear-cut answer to that as of now, but I would like to leave you with a couple of questions. Yes, we know that interventions such as the nurse mentoring intervention did see effects in terms of improving the quality of care, at least the clinical bit. But the question in front of us is that the fact that these programs are being so uniformly applied across all settings, and the findings that are emerging from studies such as these, repeatedly telling us that context plays a huge role, that every facility is actually has a unique set of context, has a unique story to tell. Is it really the right approach for us to apply the same set of strategies everywhere? There's also a huge amount of data emerging which talks about immense heterogeneities being present even within the facilities in the same intervention areas. So the question really is, how do we address some of these challenges? How do we address the issues of heterogeneities, address these issues of challenge, of context? As Michelle was pointing out earlier, I mean, the programs need to be flexible. Can we be flexible enough in terms of having differential strategies in different geographies and different facilities? Can we leverage some of these understandings, some of these knowledge that are emerging to use context as an enabler to drive change and thereby pushing the frontier of quality improvement across facilities? Thanks.
Thanks very much. I'm looking forward to the conversation we'll have in about 5 minutes. Next is Vishawajeet Kumar, founder and CEO at Community Empowerment Lab. He's a global health scientist and a passionate advocate for enculturating science to address the rights of women and children's health in disadvantaged communities. Dr. Kumar founded the Community Empowerment Lab to bring together a transdisciplinary team of scientists to co-create solutions at the confluence of science and local wisdom with community members in rural India. Thank you.
Thank you very much. So before I begin, I have to admit that this has been very unconference-like. To begin with, I thought it was more like an Oscar ceremony. It rocked. So congratulations. It was amazing. The second was the venue. I've never been to a conference room where you can have a 360 degrees almost view of probably the best view of New Delhi. And the third was just a stellar and intimidating, array of speakers. And so this has been deeply illuminating for me, and deeply. Thank you so much. And for me, I'm in infancy when it comes to health systems research and particularly quality. And I've largely been embedded in communities, and most of my work over the past 1.5 decades, which I've spent graying my hair, and I was just competing with Devendra today, who had more gray hairs than me, and largely has been in UP trying to understand why newborns die and what do we know about it, and trying to design or co-design behavior change interventions and see and evaluate that for impact. My introduction into quality of care, and particularly person-centered care, quality of care actually began with our work with Atul and Catherine with our Big Bang Betterboard trial. A huge trial there. We believed we had an answer, and we came in, implemented in this complex environment known as UP, and you all know the results that we intervened with probably the world's largest study on maternal and neonatal health around the time of birth, and we saw no impact on mortality. It only goes to say how little we know about this amazingly complex and fascinating system. And I don't think in this last 3.5 minutes I'm going to give you anything more than what I know. The second person I have to admit here is probably the most, in the frequency of which his name crops up today is probably at the highest, is probably leading, is Dominique. Professor, that's his, he was the PI of the study, and he's been just very kind to invite me to be part of it. So this one is focused on one of the studies which is known as a Q+ study. And I think it's very important that the origin of the study is very important. The idea for this study actually emerged from the National Health Mission leadership itself in UP. And I think that's very critical. And thanks to the leadership of Dominique to be so accommodating to say, well, how can we answer? And the question was that we do know that this is a complex system, but can we actually look at it and see if we can find drivers of some positive behaviors within the system? And so, as you know, it's a very complex question, and we have tried to answer. We don't yet have an answer, but we have some preliminary results that we want to share. And if it's too difficult a question, Dominique is here to answer it. So this is more focused on the clinical best practices and the person-centered. That's the kind of subdomain that the study is about. And so this essentially, the National Health Mission essentially did a quality of care assessment across both the process and structural determinants across all its facilities. And then we selected over 200 facilities that had over 200 births every month. And out of which we actually selected, we stratified by region so that it had regional representation. And then we, by level of representation, this means district hospitals, FRUs, CHCs, and right up to primary healthcare center. The whole idea was, can we get enough representative and logistically feasible samples? So we ended up with 40 of these, and each of those we administered both quantitative and qualitative questionnaires, and the quantitative was actually approximately 50 to mothers who had just delivered, so it was all around patient experience, and with one component being on patient-centered care, those 32 questions on it. And so, and then we started, we then stratified it and essentially looked at, picked up, the top 1/3, which we ranked them, and we identified the top 1/3 that were the best for clinical quality, and within that, the best 2/3, which were highest for person-centered maternity care. So this, and then that became our deviant group, that we called it as the deviant group, and the rest of them was the non-deviant, and started to look at signals if there were anything that could actually help us identify there was something unique. Overall, I don't think there were, we found too many differences between the two, but we'll just tell you what we found. And so just to have some very basic 3 indicators on, we found that those were deviant facilities. They actually had they had more 42% versus 32%, and these are all statistically significant. So they had higher 3+ more ANC visits within those facilities. There was higher, greater monitoring of labor progression as a sign of, these are just proxies for care. and they were more likely attended by skilled birth attendants, 97% to 85%. These were just some initial findings that we had. We also looked at the qualitative data. These are very initial because we just completed coding it, but there's some insights that I would bring. And these are just some quantitative one in terms of how they felt that the availability of MOIC or the job satisfaction, as you can see, it's higher in the deviant, positive deviant population. But overall, I think if one message that is emerging with our very preliminary investigation of this is at the root of all of these is human. It's not a human resource, and I think it's very important that we have always seen as human as a resource, but I think it's important that we start seeing the human as a human. And this human, I think at this point, my focus is going to be more for those. So at a more higher level, we've seen that the way we see a very clear pattern between how the culture is at a community health center, or those centers, those are within populations, and those centers that are away from populations, for example, district hospitals. What is essentially happening is that there is an interaction of these cultures. In community health centers, those cultures are largely dominated and influenced by the socio-cultural context of that particular region. While when you go to a district hospital or a tertiary care facility, those are largely biomedical culture that is largely emerges from within that institution. So these are just some initial impressions that continues to have. When we get on to the most pivotal, I would say, human in this entire seems to be the MOIC or the leadership. But I think that leadership, I would, if I have, Dominique agree, I would say it's less than leadership. I think it's more social. They're more entrepreneurs. There are no set rules. It's just that if some MOIC is highly entrepreneurial, they're able to drive certain behaviors within that system. I would assume that if instead of becoming a doctor, he would have been an engineer, I would say he would have had a startup company. Wherever he were, I believe he would have continued to use those. So I don't think they just have a higher social intelligence. They're able to connect with communities around them better. They're able to better interact with the mothers and the families who come in, and they're just able to better manage the team. It's not that they have actually been trained on it. More importantly, we also realize, and from this work and also from other, that it is not necessarily a system, but it is some form of a loose grouping that is because there is a lack of a certain purpose, and therefore not an alignment. It serves as a loose group rather than a team that is working towards a purpose. And also because the accountability is limited but largely fear-driven, then you have a self-serving individuals emerge out of the process. And when you have somebody as entrepreneurial and comes to emerge as a leader, I think it's around which people galvanize, and that's where you find a certain bump in the quality of care that you produce. So this is all that I leave you all with. Thank you very much for having me here, and then having an infant amongst giants in quality of care. I'm absolutely honored. Thank you very much.
Thank you so much, and I do appreciate everyone being so punctual. And I would like to first echo what you said by this amazing lineup of speaker and experts in this topic. I don't know when I've been at a conference where I've been sort of both amazed and intimidated at the same time by the people in the room, including yourselves. So I'm not going to take too much time to be able to open it up to some conversation, but I do want to make two quick observations. And one is sort of more general about today, where we hear everyone talking about context and the different components of that context and whether we can leverage context or not. One thing that hasn't come up, and I'm just kind of curious about this, is the whole concept of resilience, and resilience being a factor in quality or these positive or negative deviants. And I'm just throwing that out. And then the next thing that is these common threads that we're identifying about quality of care: empathy, motivation, context. What I'm hearing less about is, so what do we do? And how do we address that? And how do we do it in a streamlined way? So I, just because I have the microphone, am going to make a quick pitch in that I think that one of the best ways to instill motivation, empathy, understanding of local context is to make those providers, as the old saying goes, walk a mile in their shoes. And what I mean by that is when we do our simulations, the first thing, and it was actually by mistake that we've tumbled into this, we make the nurses play the role of the patient. She experiences care by her team of providers, everything from having a baby who doesn't breathe, a hemorrhage, being flooded in blood in the delivery room where she works, and watching from around her own facility, what everyone is doing, why and how, and being able to reflect on that for her teammates. I think that's how you're going to get them to trigger some interest in what they actually do the next day.